Are grateful for this opportunity. It's one of the first that we're ever doing, but I guess as we go along this year, we will learn new things. You see a bunch of people who probably never handled Facebook feeds before and have never handled sharing screens before. So you'll have a bunch of people doing new things. But that's how we learn. And therefore, we are happy to be a part of this, and we're grateful to you for being here with us. We have the associate editors of the Indian Journal of Urology as a part of this panel. They will all be delivering small talks, but more importantly, we will leave a significant time at the end of this webinar to address questions that you raise through the Facebook platform. So if you have questions, you can't ask them live, but please put them on the Facebook platform, and we should be able to address your questions at the end of the webinar. Let me begin by discussing why we should ever write. The question that comes up in everybody's mind is, I'm doing a good job, I'm a surgeon, my primary responsibility is to operate. Therefore, why should I ever write? And in order to address this particular question, let's just go back to when the first journal ever began. Writing began almost 400 years ago. It's about 350 years actually, when the first journal that was called the Philosophical Transactions of the Royal Society was first published. And interestingly, this journal is published even today. And the concept behind publishing at that time was to benefit mankind. And again, a very interesting fact, in the last 2 months, we've actually seen the genesis of why publications actually should occur. People wrote because there were new things that were happening around the world. There were new discoveries in science, and they wanted to share these findings with their colleagues and their peers. Therefore, the entire objective was to benefit mankind, which is what we who've been looking at COVID all around the world are seeking. We need to seek answers. Why are these things happening and what can we do to help? That was the whole concept behind publishing when it first began. Unfortunately, over the years, this changed. And from benefiting mankind, we have now moved to benefiting man alone. A lot of writing that happens today is because it is needed by the author for his own interest, whether it's for academic promotions, whether it's to get a grant, or because he has shares in a company where he needs to sell a drug or a device. Therefore, the entire concept of why people publish has moved on from benefiting the entire mankind to primarily benefiting an individual. And therefore, from being altruistic and informing people of observations, doing good and preventing harm, which is why it used to be, it has now moved on significantly to helping yourself. However, this doesn't change the fact that we are actually obliged to report our results. As healthcare professionals, we deal with life every day. We see new things that happen. If we find something good, it is our responsibility to make sure others know it so that they can use it on their patients. At the same time, if we do find something which is harming our patients, it's our obligation to report that as well to prevent harm to other individuals. Therefore, it's actually our responsibility to write. At the same time, there is no denying the fact that you do need to publish if you need to progress in life, whether it's a requirement for recruitment or for promotions, to be simply called to deliver a talk on one of these Alto platforms or a webinar to be able to announce your existence. The only solution is to have published. Therefore, it's a method of getting recognition both for your work and for your person as an individual. The other very important reason of why you need to write is to be able to question dogmas. It's often been said that if it wasn't written, it didn't happen, and that is a fact. When you write something, it has gone through a process called peer review. That means a few other colleagues of yours have listened to your opinion and have felt that there is possibly some merit in what you're saying, which is why they're allowing you to say it. That is very important, because once you've published your opinion or your findings, you've said that what I believe is shared by at least a few other people and is worthy of being noticed. That's why it's important to write. And the other important reason, which many of us in academia believe is important, is that you need to write to be able to learn to read. You see a bunch of papers which come out which say drug A is good, drug A is bad, surgery 1 is good, surgery 2 is bad. Unless you're able to critically understand the paper, you are not in a position to judge the value of what you're reading. And a classic example is actually in the current era of COVID. This is actually a beautiful era for people in writing to understand how the concept of writing changes. Is HCQS good? Is Remdesivir good? Does Lopinavir work? You get papers saying one thing or the other every other week. This tests your ability to do a critical appraisal and decide whether what is happening is right or wrong. That's why you need to be able to write, to be able to understand how to read, and to be able to understand what research is all about. When you look at yourself working in India or in countries which are relatively less progressed as compared to parts of the other world, you have another very important reason to write. There is something called a publication bias. Journals tend to publish that research which is more likely to be read. On the contrary, the diseases which are more likely, or articles which are more likely to be read, don't always refer to diseases which are more common. Articles on tuberculosis, chyluria, filariasis, conditions which we are commonly dealing with, would rarely find a mention in a recognized journal. Therefore, this is what is called the 1090 gap. The 1090 gap means that 90% of healthcare funding typically goes to diseases which account for only about 10% of the disease burden. On the contrary, less than 10% of the research spending is on diseases which account for 90% of the healthcare. And unfortunately, we in India and the developing part of the world suffer from the bulk of these 90% of the diseases. It's only now that an infectious disease has caught the interest of the entire world. So why does this matter? This matters because many of us working in areas which are undersourced and underfunded for research treat a large number of patients with limited resources. At the end of the day, each one of us is bound to treat our patients through evidence-based medicine. But where is the evidence? If we are not generating that evidence, if we are not writing up that evidence, how will that evidence ever accrue? Are we going to expect somebody in the US to work on filarial diseases when they don't even see it? It's our job to work on those diseases, on those conditions, even conditions which are seen in the West. Prostate cancer. Is our prostate cancer the same as the prostate cancer in the US? Are we treating the same spectrum of disease? Are we looking at them at the same stage? Do we have the same resources? There are tons of questions which are common specifically to our circumstances, which we need to generate data and answer. Therefore, we need to move away from what seem to be the high impact, glamorous diseases. All of us are caught by the same bug. All of us want to do a radical prostatectomy, want to work on the robot. We need to do it. I'm not taking away from the need from these surgeries. But at the same time, we also need to work on conditions which are specific to us, where nobody else will work. Or even in these diseases, addressing questions which are specific to us, which need to be answered. We also need to learn data presentation through writing skills, learning a little bit of statistics and epidemiology, and of course, working on our language. The most important aspect in this entire spectrum of writing is actually the research question. What is the knowledge gap that needs to be filled? And the most important question you need to answer yourself is, so what? So what if I've done this? So what if I've done that? How does it impact healthcare in my country? And therefore, how can I answer the research question through a PICO format? So the summary of what I wish to say about why you need to write is that it's imperative for us to gather data and to publish. Not only because the diseases that we deal with are different, but the manifestations and the implications of the common diseases in our continent are also different. And the only solution for this is to write. So thank you very much for giving me this opportunity. I will stay on as the moderator and will take the questions at the end. And I would now like to invite Arvind Panda to talk about the basics of critical appraisal. So Arvind, if you could share your screen, yes.
Thank you so much. I'd like to share my screen. I think I have to, how do I do that? Yeah, desktop. So is this okay? Am I, okay? Okay, I will be talking about the basics of critical appraisal. And already Dr. Rajiv has explained very beautifully how and why we should write. When we try to understand medical literature, and this seems to be as good as a time as any when we are in the throes of the COVID pandemic, half of what we learned in medical school will either been shown to be either dead wrong or out of date within 5 years of graduation. Thus said David Sackett. The trouble is actually that no one can tell us which half is actually going to be wrong. So what is critical appraisal? It's we have now, even now you can see you have information overloading in medicine in this COVID era. What works, what doesn't work. There's so many things we really don't understand about it. There are many myths. So when we talk about critical appraisal, it's basically the process of carefully and systematically examining research to judge its trustworthiness, value, and relevance in a particular context. And this was stated by Burns as it's never more true than it is now. So why should we bother? The reason for bothering is published research is not always reliable. And now, if you look at it, a lot of papers which are actually coming in as preprint. Preprint means it has not been peer reviewed and it has been put on the net uh, because the authors feel that it is going to benefit society. And only of all the published research that we have, and forget about preprint, even if you look at peer-reviewed public research, only an estimated 2% is judged clinically relevant. And now even our patients are better informed. They come to us having read the material and having Googled their problems. And one more thing that we are seeing more and more now is something called reversal of medical practices. This has really been seen in the case of PSA screening in urology. We have got new guidelines every day. And then, of course, if you look at the Astral trial for renal artery stenosis, we have talking of routine coronary artery stenting in the Courage trial, or the CAST trials, which in cardiologists looked at antiarrhythmics in post-myocardial infarction. All of them reversed what was currently practiced. So we need to know why medicine adopts this ineffective or harmful practice only to abandon them late. But what critical appraisal is not is negative dismissal of a piece of research, assessment of the results alone, not looking at the context. And this is something to be done by expert researchers based on detailed analysis. But finally, the basic thing can be done by anyone. It is not necessary that you have an expert statistician to do critical appraisal of a paper. So what you will gain from it is to focus on the highest quality evidence. We stay up to date in our own field, and we can extrapolate this evidence into our own practice. That's very important. So how do we do? When we look at critical appraisal, we can look at checklists are actually available and ask simple questions. We need to question the answers, not just answer the questions. And there are different checklists available for different type of studies. We have systematic reviews, RCTs, each one has a different checklist. These checklists actually help you focus on the most important aspect of the article, and that's what we need to see. For example, this is called a critical appraisal skills program called CASP, and they have checklists which can help you make sense of your RCT. And this is a sort of a web-based app, just an example. The key step we need to know is what the checklist also help us answer is what are the results? Are they significant? Are these results valid? And how was the research done? So how will these results help me to work with my patients? So what are the implications of this? One, does it produce new knowledge? But more importantly, will it change my current local practice? So there are a lot of resources already in this available, which are actually pre-appraised research. For example, the Cochrane Library. And secondly, the database of abstracts of reviews of effects, which are available under the NHS. So just broadly, how do you do it? You decide on the question you want answered. You look at your gaps in knowledge. Is the gap, for instance, if you look at you look at COVID-19, we know the etiology, but we really don't know much about the management, and we are still learning every day. So even if you look at every inpatient that comes in, if you really analyze how you are managing that inpatient, you find there are 5 knowledge needs for every inpatient and 3 for every 2 outpatients. So it helps you focus on your search if you have a question that you want to answer. Secondly, you have to convert that information need into an answerable question. This is very important. And then we have to collate the best available evidence. We have to search the literature and pick relevant articles. Then we have to critically appraise the evidence for the validity and for the applicability. Again, if you look at validity, there are two types, internal and external. That's completely a separate talk. And then finally, we need to integrate all that evidence into our clinical practice. That's very important. So already, I think Dr. Rajiv has gone through this PICO thing. The PICO tool basically helps you to define the question. So you have a population, you have an intervention, you have a comparison, you have an outcome. That's what is PICO. Then you search, and then you appraise the evidence, then you decide on that evidence, and then evaluate, and when you wish to adopt this evidence into your practice, or you don't want to adopt. So this is what it is. PICO, the population, intervention, basically management strategy, diagnostic test, or exposure. You have a comparator, and then you have outcome. So when you look at the question of intervention, you have to build the question. So how do I describe, this is the patient problem, how do I describe a group of patients similar to mine? You have to be precise. Secondly, you have to intervene, that which intervention arm am I considering, what is the main alternative, and what do I hope to accomplish? So for the example, in patients with LUTs without comorbidities above the age 50 years, would the addition of PD5 inhibitors to standard combination therapy, when compared to standard combination therapy, help? Will it result in improved LUTs and better erectile function? That's sort of a question that we can see. So we need to have a proper search strategy, and we need to search for high quality evidence quickly and efficiently. And once you find a relevant article, you need to ask, what is the PICO of the study? Is it close enough to your PICO? What is the internal validity of the study? How well was the study done? Is there a relationship between the two variables? And question 3, what do the results mean? Could these results have been achieved due to chance? Finally, what type of research question does the study pose? Is it a question about effectiveness of treatment, or is it a question about the frequency of events? Is this, for instance, we have a case report, a study now in this COVID era, which says there is a lot of SARS-CoV-2 in the peritoneal fluid, and a lot of people question whether this was to be contamination with blood and all that. Now, that was not the question this study started out to answer. So, is this study's research question relevant? Does the study add anything new? Was the design appropriate? Did the design permit the aims of the study to be addressed? Are the variables and the endpoints well defined? What statistical analysis is employed to characterize this endpoint? And does it address key potential sources of bias? Lesser the bias, the more the internal validity of the study. So look at the references also. Do the authors cite their own publication? This is quite important. And are there any recent references in the last 2 or 3 years? Is this analysis up to date? Finally, check for plagiarism. Have they copied it from some other paper? There's also another misconception when we look at the critical appraisal, that experimental research is more scientific than descriptive or qualitative research. That's not true. This type of design or method does not render the study scientific. We need to choose the correct method for the correct question. So finally, I like to end by saying the essence of independent mind lies not in what it thinks, but in how it thinks. And to conclude, critical appraisal consists of a set of questions that are designed to determine how well the study has been designed and carried out. The results are credible, but they are not a guarantor of the truth of the study. Thank you so much.
Thank you, Arvind. And we'll now move on to the third talk, which is on planning a study by Anil Mandhani. I'm grateful for the questions that are coming up on the Facebook feed, but we don't want to interrupt the speaker, so we'll address all the questions at the end. Please have them coming, and I'll take them up one by one at the end of the webinar. So the next presentation is Anil Mandhani, and he'll be talking about how to plan a study. Anil, I hope you've got your screen share going now. Perfect. So we can see your messy desktop.
Yeah, I try not to be as messy as my desktop, but can you see me?
Hang on a second. I don't think I can see you. No, I can't see you, but I can certainly see your desktop. So if you just do activate your PowerPoint, we can at least be ready to go.
Can you see my PowerPoint now?
Yes, perfect. Just carry on.
Okay. No, but actually I have logged on through my phone, so I can see myself on the screen.
No, we can't see you, Anil, but that's okay.
Okay.
We'll work on that later. If you can just carry on with your talk. I'm going to mute myself now.
Okay. I must thank young Turks in urology who have made this group of urological learning through others. And I really appreciate that effort. And I'm delighted that they're keen to learn about this kind of activity. So if you want to be a good researcher, want to do a real good study, you need to be a good reader also. Unless you read journals, you cannot be a good research person, because you cannot generate a research question. So let's see, what do I have to share with you? Unfortunately, everybody looks at surgical side of medical literature with an eye of suspicion, because there are a lot of biases. So one needs to be very careful whenever one considers having a surgical study. So let's come to the first point, that is technical skill, which is surgery itself. So the basis of any medical trial is a null hypothesis, that is called negative visualization. Means you need to say that the current or the new procedure which you are comparing with is always bad, which is unfortunately not so, because you have new technology which you want to test. So you already start with a bias, because there is a commercial pressure to justify the cost. So in surgical literature, that is the main problem. That's the reason still in 2020 we do not have one single best treatment for a surgical treatment for benign prostatic hyperplasia. The second group of biases we do see in surgeries whenever you do a surgical study is non-technical skill. I mean, there are various confounding factors which govern the outcome, which are far or away from the surgical skill. The most important is cognitive skill. I'm sure you may see different kind of results with same robot being used for radical prostatectomy done by 100 different surgeons. Even if they follow same surgical steps, outcome would be different. Another important factor which we ignore is communication. Unfortunately, in this coming era of COVID disease, now everybody has to wear a mask. So it has been documented, particularly in robotic surgery, the communication gap results in almost 40% of complications. And of course, personal resource factors like how stressed are you and how fatigued are you. So these factors are never considered whenever you analyze the outcome in surgical literature. So you heard Rajiv and Arvind talking about PICO, that is how to raise a research question. Before that, before you're planning a study, I think you need to find, as Arvind said, a knowledge gap. Why do I want to do this kind of study? That is the biggest question. Then you think about the originality of your study, whether it's relevant to your population or your practice. Then what kind of study population you have. I know a lot of centers in India, they do a lot of transplants. Some centers, mostly the young Turks, are doing a lot of stone work. So there is tremendous scope of doing a study as far as stone management is concerned. And of course, you need to be ethically sound whenever you are planning a study. You should, if you're testing an entirely new procedure, you need to do it on animals first. Now you have thought of doing one study. So what are the steps of actually doing this study? Research question. I think he gave you a couple of examples. So that is the best thing to start with. Then comes the surgical skill, research skills. That is methodology and biostatistics. You need to be well versed with these two pillars of any good study before you really think of starting a study. Then, of course, you have to define outcome. Unfortunately, again, there are many biases when we skew our outcome to get the positive result from the study. I'll explain to you how do you skew or how do you tweak the outcome to have favorable results. And of course, you need to do literature search, whether you're duplicating a study, because unnecessary, you would be wasting your time if you continue doing the research, which has already been done in large number and from good center. And the most important thing is that even if you have followed all those steps, you need to present your plan to your colleagues so that they can give you feedback. Because whenever we plan a study, we are already start with so many biases. So let's see how to frame a research question. As I said, you need to look at the population you are getting in your practice. Like talk about a center who is doing a TRUS or MR fusion biopsy 3 to 5 in a week. So they can think about, the way we are going forward, that we would be only targeting the lesion which are visible in MRI. So that can be thought before, and that can be compared with the conventional biopsy. Then if you're doing good number of transplant, you can think about results depending on number of arteries in donor graft kidney. Maybe you can compare open or robotic if your center is doing robotic transplant, and you come out with honest and altruistic data, which would be really useful to the world. And again, a stent is a problem. Many centers they put stents, some centers they don't. Maybe you can come up with a trial of randomizing these two. Like some surgeons, they tie the stent with the Foley catheter and remove it at the time of removal of the Foley catheter. And there is a randomized trial on this also, which was published a year ago. Again, this is the main bulk of problem we see in our practice. Like you young guys, I've seen you doing supine PCNL and a lot of RIRS. I'm sure there are more than 50 urologists who are doing more number than one, what Oliver Traxter does. So why can't we generate or produce Oliver Traxter? So why can't we have guidelines on supine PCNL? So we don't have dearth of material. It is the lack of intention or will to do a good study. The second step I told you is to have some knowledge about research skill. And two pillars of research skill are study design, which is the key of thinking or starting a study, and second is biostatistics. To understand these two, I think you need to focus on this slide. This is a very important slide. In all medical literature, what you first decide is about the outcome. In statistical term, we call it dependent variable. So outcome could be disease when you are analyzing risk factors. Like I want to see incidence of bladder cancer in smoker. That would be disease would be the outcome. Bladder cancer would be the outcome, and smoking would be the risk factor. Then progression or death of any treatment, mostly in cancer surgery. Then complications of your surgery, like you're comparing homium TURP with conventional TURP. You can look at the complication apart from the success or outcome, and the response outcome mostly in drug trials. So these are the broadly four categories of outcome you study in any kind of study. So when you study these outcomes, you have independent variable like factors which govern these outcomes, like risk factors, diagnostic tests, drug treatment, and a surgical intervention. So now you remember this slide, and let's talk about the studies. Now, when you have control of these independent variable, when you have control of these independent variable in your study, then you have experimental kind of study. That means you can measure or you can record these independent variables which govern or which affect the outcome. Then it becomes experimental study. So that is randomized or non-randomized. And if you don't have control on determinants or affect variables affecting the outcome, you're just recording the data, the things, mostly the causation studies or things which have already happened, and you're just recording it. So that becomes observational study. I have seen many abstracts on outcome of ureteroscopy in 10 millimeter stone in lower ureter. They call it observational study. It's not an observational study. It is an experimental study. You are studying the outcome of one procedure on treatment of a stone. That may become non-randomized, but it is an experimental study. Then again, observational study is broadly cohort study and case control study. So as I said, observational study, you have no control of determinants or factors affecting the outcome. So when you have disease outcome, when you have already present the disease outcome, suppose you're analyzing 100 patients of bladder cancer, you want to study the impact of smoking. So you have the outcome, then you assess the impact of determinants, which have already happened. It's called cohort study. So this could be retrospective and prospective. Obviously, you don't have the disease, you have smokers, and you just follow them up for 20, 25 years to see how many of them are developing malignancy. So this prospective cohort is also called longitudinal study, and it is I think it is many times it is considered as better than randomized controlled trial, but it's very difficult to perform. And the case control study, again, it is similar to retrospective cohort when you have the outcome and you are studying the determinants, but you have a control along with study group. So that is the broad difference you need to understand about the study design before starting your study. So the RCT could be single blind, double blind, or non-blind, and non-RCT mostly case series, as I quoted an example of ureteroscopy. The observational study, again, as I said, it could be prospective, longitudinal or retrospective cohort, and case control actual or cross-sectional study. The second pillar is biostatistic. You need not to be expert in biostatistics, but you need to understand basics about biostatistics. So whenever you are doing a study, you are capturing data. If your data are continuous, means any data with decimal, that is continuous data, it's not discrete, then you have different set of statistics. And when you have nominal or categorical data, like you do pyeloplasty, you have outcome as success or failure, that becomes nominal or categorical data. So you apply different kind of study, different kind of statistics. So this is a basic understanding one should have before planning a study. Then the third step, which I discussed, was outcomes. I know about many trials done in RARP. When we talk about the urinary incontinence as the outcome, we have variation from 4% to 21%. Why is it so? Because we do not define outcome uniformly. Some define as one pad, two pad, three pad, or interpretation is based on many biases. So why can't have only one definition, like no leak at any cost? So that explains the tweaking of outcome to have favorable results. Another examples of arbitrary endpoint, like you have a technology, you are making a simple procedure more complicated by this new technology and saying that this is non-inferior to the existing one, the gold standard. So these non-inferior trials are not good because the inferiority margins are defined by us. So if some new procedure is non-inferior to the existing one, so we have defined that it should be within 10% of difference. Why 10%? Why not 0%? So that is the beauty of statistics. You need to understand. So you need to read and understand the articles to do a good study. Then again, another example of a 4-point improvement in symptom score. Now, we need to understand there are a lot of placebo effects. Most of these trials, now if you look at anticholinergic drug studies, randomized level 1 evidence, the difference in improvement in urgency is to the tune of 1 or 2 points. So that could be because of placebo effect, but everybody's using that drug. So that is the beauty. If you read article critically, you understand how we tweak the outcome and get the result in our favor. Similarly, improvement of pain score by 2 points. This the first trial of zoledronic acid in managing pain and severe prostate. The significant difference was just 3 points. Now imagine if patient is having improvement of pain from 4 to 1, that becomes significant. It is ridiculous. The pharma company made a lot of money out of this, but now we understand that it is really not useful.
Another 2 minutes, Anil, please.
Okay, I'm just going to wind up. So, and most of the cancer studies, we just talk about improvement in survival from 1 to 3 months. So these are arbitrary endpoints. So you need to be careful about defining the outcome points. Literature search, you need to be really good in doing that. You need to select latest article, but it's not that you're selecting articles which are you have already thought in your mind that I am going to have a positive results, and you select those articles which have given you positive results only. So you need to be very careful. The last step, which I said, is peer review. Now, if you thought about a project, let's see, you have thought about doing a study on 1 centimeter pelvic stone, comparing mini perk and RIRS, and the outcome is success and complications. So when I subjected this study to peer review, presented in front of colleagues, they suggested a lot of significant change. Why did we forget ESWL? Why not if you include stones of more than 1400 to make this study more useful to study? Then stone clearance, why not CT? Why using X-ray? And why don't you compare the cost? So that is the beauty of peer review. You get to know the deficiencies of your thought process because you're thinking alone. Nobody would come to help you when you're planning a study. You have to plan your study, but you need to present it before your colleagues to get positive feedback. So at the end, I must say there is no greater harm than that of time wasted in poor planning. So you need to really plan your study to get that study, see the day of light in a good journal. Thank you very much.
Thank you, Anil. That was very well done. And now that we've understood what various types of studies are, the most important one to conduct in terms of level of evidence, but also undoubtedly the most difficult one to conduct, is a randomized controlled trial. And Santosh is going to be talking to us about how the randomized controlled trial works. Santosh, it's over to you. Probably about 10 minutes to 12 minutes, please, Santosh. Thanks. Santosh, your audio is not, we can't hear you.
Can you
Yes.
hear?
Yeah.
Anil, to unshare.
Anil, can you stop sharing? Can you press the button to stop sharing? Santosh, if you share, it will automatically become your privilege.
You cannot share screen while the other participant is sharing.
You can override it. But anyways, Anil, can you please stop sharing? Just press the share button again.
I am. Yeah.
Anil, are you there? Okay, right. Santosh's screen is now here. Perfect. We have your screen, Santosh. But your audio is a little sketchy.
Coming as close to the computer as possible. Is it better?
Stay there.
Okay. So I'm going to only concentrate on randomized control trial. And thanks, Arvind and Anil, to make my job easier, as you have described the other things. So clinical decision making has gone a long way. It has started from the time immemorial, from Galen's time, when he felt that he was like the Lord. It is I and I alone who have revealed the true path of medicine. And from there, now we know that this type of eminence-based medicine is no longer acceptable. And now everybody is looking at the scientific evidence that is available. And one of the best ones, I'll say happily, that I have been given to talk on is on a randomized controlled trial. And what is evidence-based medicine? Basically, judicious use of the current best evidence in making decisions. So you may not have a randomized controlled trial as the best evidence, as a lot of these meta-analysis done nowadays, you'll see that they were based on very small case series or even small randomized controlled trials, prospective or just retrospective. So not necessarily, but evidence-based is whatever evidence we have, using that, the best one to go ahead. So I think you've seen this before also, and this is the hierarchy of the evidence, and you see there above the RCT, the best one is a meta-analysis, which would take up the best evidence which is available. If RCTs are available to take that, and that would be leveled as 1A evidence, and usually based on that, the recommendation would be level A, means it is recommended you should do that only. Individual RCTs are usually 1B evidence and still are very high in the hierarchy. So if possible, you should try to take evidence from these. What is a randomized controlled trial? It's an epidemiological experiment in which the population is randomly allocated into the study and the control group. So the words are very important, randomly allocated. So they receive a treatment or don't receive a treatment, and then You decide what is the outcome is there, the primary outcome and the secondary outcome. And based on that, you make a decision as to what should be the treatment. So very interesting, I probably spent 1 minute on the history. The first recorded randomized controlled trial was on the use of streptomycin for treatment of tuberculosis. Now, if you want to do a study like this today, it's just not possible because the patients were defined that this is the group of pulmonary tuberculosis patients who will have treatment. They were given streptomycin or no treatment. So actually, if treatment exists, giving no treatment is not justifiable ethically. So why was it justifiable then that there was no streptomycin available at all? There was so less streptomycin produced and it was being used for meningeal TB and other things which would cause death, that pulmonary TB, early TB would not get the medicine for treatment. That is the reason it was the statistician's paradise that they could use no treatment also as a control arm. Today, if you have a disease and if you have treatment for it, you can never use no control as a treatment. This is probably the first study where actually allocation concealment was done. And they went into depth deciding as to how to do it. It started in 1946 and published in 1948 in BMJ. The original article, you can Google it online. It's a very long article, but very interesting. This has set now the way in medicine we treat. And then if you see in urology itself, most of our treatments as of today are based on randomized controlled trials. So we are following very good evidence-based medicine as far as drug treatments and a lot of things like BUR, surgery versus no surgery, or prophylaxis. Those things are concerned, we are doing. However, not all surgical treatments have been put to the randomized stress, and whichever have been put to also haven't given great results. Like if you see the recent trial on a robot for oncological surgeries for prostate and for radical cystectomy, you'll find that there's not great difference. We haven't done, but still we do follow some evidence-based medicine there. So why is it? You know, this was a little old article from Lancet 1996, but I don't think things have changed much. You know, even in IJU, when we review papers, sometimes in the whole year we don't find randomized control trial, even one published, which is actually not good, because in a conference you see many randomized control trials are presented in our national conferences. So just about 7% of all the articles that are presented are randomized control trials, and you'll come to know about it. Why? So study cannot be done if you don't know what is the question, and the type of study will be decided on the question. I think Anil has very well elaborated on that. I'll not go on to that, but why do we do RCTs? Because this is the gold standard for pathological research. The intervention is in our hands, and whom we give the intervention, we decide inclusion criteria, exclusion criteria, and give. And then we look at the primary outcome, and we can say, at least the internal validity of this is very true. If you keep doing that experiment in the same place with the same people, you are going to get the same result. So it takes off all the selection biases, and that's why the reports are so valid. Why we need RCTs today? You can Google on any subject and you'll find thousands and thousands of literature, and how do you select as to which one you should read or which one you should follow? So there you need RCTs or meta-analysis of RCTs to make your decision. So amongst the whole gold mine, you have to figure out where to go and dig and take. So when there is a question of equipoise, means you don't know whether this is better or that is better, as a treatment thing, we use a randomized controlled trial. So there should be genuine uncertainty within the expert medical community, not just an individual or institution. So this is the basic design. You have a population, you have a question, and you decide as to which one you're going to take with the inclusion-exclusion criteria, and then you randomize, and then you see the outcomes. You define the outcomes and see, and the sample size is based on how much difference you want to see and how much follow-up you want to have on the follow-up. Any study you're doing, I request you to go to the Equator Network, and there you will find for all the studies there. On the first is the randomized controlled trial and consort, but other guidelines also there for other things like observation study, and you use the stroke for systematic reviews, Prisma. I'll not go into details of that, but you should go to the Equator Network because it gives you a very good checklist for the randomized controlled trial. That 25 points starting from whether randomized control trial has been mentioned, because it's such a good level of evidence that you should mention it in the title itself. From there too, if you go to the 25th point, I think it is, you should declare the source of funding, because a lot of these drug related trials are costly to perform, and usually it is sponsored by a drug company, and that adds to the, uh, you need to tell what are affiliations you have or wherever the funding has come from to complete it. So there are 25 points in the checklist. You have time, you can go through it. And when you submit a randomized control trial, you'll be asked to give a consort diagram. So this is what it is. Enrollment, what is the criteria, how many you assess, and then how many were excluded, then how many randomized, and how did you randomize, and how many lost to follow up, and how did you do for the final analysis. So this is called the consort flow diagram. You should give this. You should not just give us these last two boxes that this was the control and this was the cases and this is how we got the results. So that is not acceptable. Now, if you have planned a study, you should first go to the institutional review board. Don't think of them as an impediment to your study. They will facilitate your study, find out if there is any lacuna, and before you start, they will make sure that all the things are ironed out and your study can go on smoothly. And they also follow up with the data safety monitoring board. DSMB will come and make sure that you are going ahead with the project properly. The next thing that you need to do is to go to this CTRI website and register your trial before you start recruiting your first patient. It was decided way back in 2009, and actually all the journals have decided that they would not publish a randomized control trial if it is not CTRI registered. But unfortunately, we still have randomized trials or trials which are not registered. It's not just for randomized control trial. You have non-randomized trials. You can have any trial registered on this. DGCI recommends that you should have your trial registered on this if you want any licensing. So it is a very simple thing. You have to just think. Why we do it is, before you started, what was your criteria? It is cast in stone. You cannot change it later, and we can, anybody who wants can look at it. So that's the way the CTRI works. Consent is one of the most important thing in a randomized control trial and should be given to the principal investigator, because the way you consent is what determines whether the patient will do the trial properly and follow up. Because if your follow up is inadequate or the trial basic protocol is not followed, your randomized control trial will go for a 6. So the consent is the heart of the trial and should be left to the most person who's most sincere to do the consent, so that patient feel involved in the trial and they're contributing to science. And
Santosh, maybe you want to stop your video feed. Your voice is breaking.
My voice is breaking badly. Just a second.
So maybe you can turn off your video feed and continue with just the voice.
See if I can use the mic. If that is any better?
Much better.
Just a second, give me. Is it any better?
Much better.
Okay.
Just carry on. Yeah, thanks.
Okay, thanks. Consent is the most important thing, and don't leave it to the junior most and the person in the ward to do it. The better consent, the better the follow-up. Biases, I think Anil has elaborated. There are different biases, and each biases you have to intervene separately so that you can take out the bias. And a randomized control trial is supposed to have the least bias. Now, why to randomize is because we know a certain group of confounders, and there are a lot of confounders that we don't know. And if you randomize properly, probably all the confounders will be taken care of. So reproducibility of the study is very high. Allocation concealment, most of the time people think it is blinding, but again, this is very important. This decides as to how a person will, what intervention he'll get, and at what point you will know when to give that. Usually we have envelopes which we open, and it will tell you whether patient goes into treatment arm, control arm, placebo arm, or whatever arm. And that usually is opened only at the time when that needs to be done. So that way it removes a lot of bias. If allocation is not concealed, a person may choose a different therapy or try to recruit a different patient as the next patient. Blinding, I think we have already talked. Follow-up, there's a lot of leak in between the study and the end. And unless you define that, now if you have the consort, it will tell you how many actually followed up. And how the data is analyzed. Usually what we do is the intention to treat analysis.
So if a person was supposed to take a treatment, then he goes into the treatment arm. If you are supposed to take the placebo, he goes into placebo arm. Despite he has taken treatment or he has gone to placebo later, we do not change. So that is intention to treat analysis. If you don't do that and you go only by who took treatment or who took placebo, then it becomes a per protocol analysis. You should know subgroup analysis can be done, but usually the numbers taken or the sample size is calculated on the primary analysis, and usually the rest of the things should not be taken. It should be taken with a pinch of salt, I would say. So what is a high quality randomized trial? I think Arvind elaborated a bit on this. So all the things that needs to be done, whether they were done and how rigorously they were done, based on this you give points. And so just a randomized control trial doesn't mean it was very good, but how much adherence was there to this protocol, how many followed up, how many finished follow up. Based on this you give points, positive or negative, and you can rate. There are various systems to do that. Now RCTs are rare. As I said, only 7% of literature is RCT. There is a problem with RCT with surgery. You cannot do a placebo and a RCT with a surgery, because a patient knows whether he had, and it is unethical to give anesthesia to a patient or incise a patient if you don't do surgery. So there are issues to blinding and this thing with surgical treatment. But yes, between two surgical treatments, it can be easily done. It is difficult to perform. You have to have it prospectively. You have to have the very strict inclusion exclusion criteria, and then the follow-ups, and it requires a lot of manpower, money. So they are difficult to do. There are drawbacks, not that it is absolutely flawless. There is cost, there is time, there is manpower, and ultimately if it is industry sponsored, there's too much money in a drug trial. Say immunotherapy nowadays, it's so costly that you have to be dependent on the industry to sponsor it. And then whether it gets published or not depends on the industry, or what gets published may not be what started with. So they are the drawbacks of RCT. This is actually a joke. It was published in the British Journal of Urology, British Medical Journal. Can jumping from a parachute prevent death? A randomized controlled trial. And so there are things that don't need to be put under randomized controlled trial, don't need to put them so rigorously under randomized controlled trial. And you have to be very careful of how things are done in a randomized controlled trial. Just because randomized controlled trial is there, it doesn't mean that it is very good evidence. So I'll just summarize. It's the gold standard, cornerstone of evidence-based urology. It has its own problems with ethics, feasibility, and cost. Trial should be very transparent. It should have mature research questions, and they are best used for evaluation of new drug or therapy, and they make the policies for governments and the centers. Thank you very much.
Thank you very much, Santosh. That was very well done in a reasonable period of time. We will move on to the next talk, and Apul Goel will be talking about common mistakes in writing. And again, Apul, if you could please keep it down to about 10 minutes so we can get back on track. So Apul would be talking about common mistakes in writing.
Thank you, Rajiv, and thank you, Alto team, for organizing this masterclass on paper writing. I'll be discussing, highlighting the common mistakes that we all do while writing a manuscript, while preparing a manuscript. You can liken an article to a human being. The soul of the article lies in the research methodology. Whether you chose a relevant research question, depending on the research question that you have chosen an appropriate study design. Santosh mentioned about the randomized control trial. Anil mentioned so many other trials, a simple comparative study or a observational study. So depending on the research question you design, you identify the study design, identify the appropriate methodology, follow up, appropriate statistical analysis. So all that comprises the soul of an article. Then once you have the data that is ready, or the soul is ready, you give it a body or the presentation, which is the manuscript writing. So these two aspects are very closely linked, and whether an article is accepted or rejected depends on both these factors. I'll be discussing the second component, that is how to prevent common mistakes while preparing a manuscript. So I'll be, instead of telling you theoretical knowledge, giving you theoretical aspects, I'll share with you real scenarios, real papers that were submitted, and I have peer reviewed them to give you, to show you the real problems that we encounter, the common mistakes that we all do. The first thing that attracts you towards an article is the title. The title should convey the theme or the message of that article. It should be self-explanatory. And already Arvind has discussed about what PICO means, but try to incorporate this PICO concept in your title as well. For example, here you have 4 examples for the same articles, but if you see the top one, effect of light and temperature on growth of population of the bacterium E. coli. So if you see PICO here, population is E. coli, the intervention is effect of light and temperature. There's no comparative arm, but the outcome is growth of population. So out of the 4 options, the top one is the best. But still you see so many issues in the papers that are published actually, where the title is misleading. For example, this study that was published in International Urology Nephrology by Sussman et al., novel pericatheter retrograde urethrogram technique is a viable method for post-operative urethroplasty imaging. Because our center, we do a lot of urethroplasty, so we decided to discuss this article in a journal club. But when discussing, we realized that the title did not match with the theme of the paper. So we wrote a letter to the editor, which was published. And let me read this, what we had written. We feel that the title of the article is misleading. It seemed from the article that the authors will describe some unique method of pericatheter retrograde urethroplasty because they mentioned novel pericatheter study. But what happened, the article seems to outline guidelines regarding optimal time for post-operative imaging in men undergoing urethroplasty. The timing for pericatheter RGU after urethroplasty was the basic theme of the article rather than the technique. And moreover, there was nothing novel. So this was published and because there was a mismatch in the title and the content of the paper. Another big study evaluating the US data of trauma, the trauma registry of United States, where this was published in a prominent journal, Clinical Utility of Routine Follow-up Cystography in Management of Traumatic Bladder Ruptures. Because again, this is a common situation. We read this article, but we realized that they have included only uncomplicated bladder ruptures, which included only those patients who did not have concomitant urethral, bladder neck, trigonal, or ureteral injuries. So only patients with uncomplicated ruptures due to blunt trauma were included. So I think a more appropriate title would have been Clinical Utility of Routine Follow-up Cystography in Management of Uncomplicated Bladder Ruptures due to blunt trauma. So we were misled by the title about the content. So your title should match with the theme of your paper. Then there are so many authorship issues. I'll suggest anyone who's interested in writing should create their own ORCID ID. And authorship issues are common. For example, this man was a director and he wrote 77 papers in 1 year. So superhuman brains or a big fat lie. So I have also faced this problem. When I was in 2016, when I was relatively more free, whichever articles we used to present in the journal club, we used to, if we felt appropriate, we used to create letters to the editor. So once we wrote this letter, the manuscript was ready. I told my resident to upload it, and he went to the resident's room, and there were his friends sitting. So everyone, you know, the names of so many residents were added. So although this paper was rejected because it was not considered to be of sufficient interest, but the editor also said it is unclear why a letter to editor should have 8 authors, although it had 5, but this is what the letter we got. After the title, the next most important aspect of any paper is the abstract. It is usually the only part of the article that is read. So the entire article is not read so often, it's the abstract that is read. So it should have the summary of the article and should include all relevant data. and it has to be standalone. If you read an abstract of an article, you should understand the entire paper. So because of the word limit constraints, because usually it is not more than 250 words, so writing an abstract is definitely challenging. And this is the portion where often there are mistakes. So if you see, this is a real paper that I reviewed. So if you see, it was on a modification of a semi-rigid ureteroscope that they have used for even renal stones. So everything is fine. The method is fine. They have seen the clinical data of stone location, everything. But then they start the results by saying the success rate of one stage operation was 94% and the operation time was so many minutes and all that. So you can't interpret the results till you know whether they included children also, what was the location of the stone, what was the size of the stone. So all these information is lacking in this abstract. So you can't interpret all these things without knowing all this basic data. And let me tell you, this is a very common problem. The same problem, another article where they have evaluated the quality of life. They have administered a questionnaire looking at the quality of life of 50 patients who underwent a radical cystectomy with ileal conduit, and they straight away start presenting their results. So we do not know how many men, how many women, what was the stage, whether they were disease-free at the time of this, when the questionnaire was submitted, what were the complications they encountered while undergoing this surgery. So all this information is not there. So you can't interpret the results that they have shown. Another paper, you see a prospective RCT. I fail to understand why they have added the word prospective here, because RCTs are prospective, where they have seen the efficacy of tamsulosin versus colterodine in relieving stent symptoms. So if you see the introduction, so it is stent-related symptoms affect nearly 80% of patients with indwelling ureteral stents and all that. So if you see the relevant line starts in the end, we have compared alpha blockers and anticholinergic drugs in reducing stent discomfort. So everything else is superfluous, it's not needed. And if you see the results, what they have mentioned, again, this is a common mistake. Demographic of both groups were comparable. There was a statistically significant difference in urinary symptom score, pain score, but they haven't given the data. So they need to give the data. They need to give basic demographic information, which patients were included, what was the sex ratio, and then also give data here rather than giving statements. So another paper, guys versus stone nephrolithometry scoring system in predicting stone free rate. So what they have done, they have used two methods, guys score and the stone nephrometry score, and they have compared the two in predicting the stone free rate. But they have written the abstract, everything is fine, but suddenly in the conclusion, they conclude that a stone score is an ideal nomogram, simple, not time consuming, and easily applied in daily practice, and is helpful in proper patient counseling. But all these things were not seen actually in this study. It was the time taken to administer these scores was not seen. It was not seen whether it was easily applied and how it helped in patient counseling. So all this information was not there, but suddenly in the conclusion, this is mentioned. So again, you can't conclude things that you haven't seen. So this is another common mistake. We over presume. So that is not correct.
Another 2 minutes, please, Apul.
Okay, so coming to the introduction, I'll it's the place where you sell the article, telling the significance of the topic. The methods is the soul, as I said, which is the methodology, the methods that you have followed. So that is again. So I like to highlight another important point: difference between statistical significance and clinical significance. So because there's too much of fixation with the p-values, so we need to, so this is the editorial which we have written on antiplatelet therapy in bladder tumor resection. The preamble of this paper was whether patients who receive antiplatelet therapy, they bleed more. So, but if you see what the authors have done, they haven't gone into the significance of p-values, they have gone into clinical significance. So rather than measuring blood loss by performing complex analysis like measuring the hemoglobin concentration and all that, they have chosen a simple and practical surrogate to study the impact of antiplatelet therapy. So instead of measuring the statistical significance and hospital stay between the two groups, the authors calculated the clinically significant difference in the length of hospital stay of more than 1 day. So clinical significance is more relevant rather than the statistical significance. Then coming to the results, you have to use tables and figures judiciously, and it should supplement. You should not duplicate the text as well as the tables. So again, apart from methodological errors that this article had, so, but then you have to have some real, rather than going into statistical significance. So for example, for ureteroscopic treatment of ureteric stones, there's no importance of intraoperative bleeding. And again, operating time, you may say that it was clinically, statistically significant, 27 minutes versus 33 minutes. But again, if you see clinically, it has no relevance. So the discussion from being specific, you generalize your results and always mention the limitations and the strengths of your study. So this is a common mistake that we see, that these are not covered in the presentation. References, often what happens, the manuscript goes through multiple revisions and you fail to change the reference numbers. So often there are mistakes in the reference. So reference 11 does not match with Andrew, and so many problems in writing the references. Then there's another problem of data mismatch. The abstract says something else. For example, this study, it was between June 10 to June 17, but in the paper, it was December 2007 and 17. So you need to be careful. So this happens. And again, why use these fancy words? Staghorn stones, you know, 2 to 4 centimeter staghorn calculi. 2 centimeter stones are rarely staghorn stones. So already there has been a talk on equator network. So whenever you are preparing a manuscript, it's a good idea to go through this so that you don't miss out on anything. It has a checklist, because medical literature is plagued by poor reporting, and this is because of poor writing skills. So writing a manuscript, making a proper paper is extremely important, because it has been shown that in 2000, of all the PubMed index papers that were published, out of the data, but if you don't write your manuscript properly, if you don't have good writing skills, it becomes useless. So writing skills are important. Thank you.
Thank you, Apul. That was a concise summary of some of the mistakes. There are, of course, tons of mistakes which get made. And the next two talks will basically be covering a lot of issues which concern younger people, and not just younger people, even people who have been well in the field. And this talks about the mistakes in terms of misconduct, plagiarism, and fraud journals. So the first talk will be by Arvind. He'll talk to us specifically about misconduct and plagiarism. I understand this is a huge topic, and covering it in about 10 minutes is going to be a challenge. But Arvind, please try and restrict it to about 10 minutes.
Yes.
So misconduct and plagiarism.
Just a second, sorry. I need to share the screen.
Yeah, we have your screen.
You have my screen, yeah.
Yes.
I'll just keep this brief. This is about, thank you so much, about scientific misconduct. Now, when we talk about scientific misconduct, we come to the point of what is integrity. We know we have all had our sporting heroes, and our sporting heroes have come down to, they have feet of clay. And so this is because in life we have been brought up saying that winning is not everything, it is the only thing. But actually, if you look at it, the integrity of the game is everything. That's very important. That's important more so in our profession where we have to keep up our credibility. So the definition of scientific misconduct means fabrication, falsification, or plagiarism in proposing, performing, or reviewing research or in reporting research results. So there's a continuum actually. You have research integrity, which is defined as the best practices that you have. And on the other end of the spectrum, you have research misconduct, which is basically deliberate efforts to plagiarize, fabricate, or falsify research data. In between, you have unacceptable research practices, and again, questionable research practices, which is actually sloppy work and lack of expertise, ignorance of policy and regulation, and other possibilities. So it's actually a continuum. So what it is not is honest error, honest differences in interpretations, judgment of data. It does not also include authorship or credit disputes. So for the requirement of research misconduct, there must be a significant departure from accepted practices, which are considered standard by the research community. And this misconduct must be committed intentionally, knowingly, or recklessly. And these allegations must be proven by a preponderance of the evidence. So you have certain definitions, you have certain keywords. One is fabrication, which means making up of data or results and recording and reporting them. Then you have falsification, which is you have some data, but there is actually manipulating of research material, equipment, or process, changing or omitting data or results, and such in a way that the research is not accurately represented in the research record. Then you have plagiarism, which is basically taking over the ideas, methods, and written words of one another without acknowledgement, and with the intention that they be taken as the words of the of the researcher. So how common? Actually, it is quite common. The assumption of it's basically sort of like a tip of the iceberg. As you can look in the picture. So we really do not know. We don't, the true prevalence, we don't know, as in the case of, we have COVID now, we don't know the true prevalence. It is actually limited with number of studies in the last 20 years and the prevalence of misconduct. But if you look at it, if you look at what studies we have, when there was a nationwide survey of students in Norway, where 11%, and Norway is one of the countries which have high ethical standards compared to others, and 11% experienced unethical pressures concerning the order of authors in the last 12 months. 10% did not find it inappropriate to report experimental data without having conducted the experiment. 13% agree that it's acceptable to selectively omit contradictory results to expedite publication. And 10% found it's acceptable to falsify or fabricate data to expedite publication. And 60% were uncertain about the department written policies concerning scientific misconduct. So why is data falsified? Actually, it is to qualify in eligible subjects, not enough time, and sometimes you lose interest. You want to please the boss. There's not enough subject for the good of the subject, power and prestige, pressure to publish. So you have it, even if you look at it, even if you have a healthcare, this company no longer exists, but they actually lied about the quality of low-cost drugs, including those for HIV, and they may have jeopardized millions of lives. Why? Because society sends mixed messages about obeying rules. It's okay not to obey rules. Rules are for fools. So who commits scientific misconduct? Can be anyone to access of data. It can be the PI, the principal investigator, the study coordinator, the study nurse, the data entry staff, the administrative staff, technicians. But who is responsible? That is more important. Most of the time, this is a transitory lap of judgment because we want it to be done quickly out of expediency, and alternative seems unviable. But who is accountable? All authors are involved in the specific data in question. It's important, therefore, all of them are held accountable. It's no longer enough to say that was done by my resident, and I really don't have any idea about why and how he did it. The primary author is, of course, responsible, but other authors also are culpable. So I'll give you some examples. Now, suppose we backdate enrollment forms to make the patient eligible. Fabricate a large report required for admission for a clinical trial. Reversing the endpoint results between treatment and control patient improve the statistics. Image manipulation, this is quite common actually. And let me tell you, it's actually possible to actually detect image manipulation nowadays quite easily. So what happens if when we start having scientific misconduct? The science is dependent on precise data. Nowhere has it been exposed more than during the current COVID pandemic. We are talking of hydroxychloroquine, we are talking of the antiretroviral drugs. Really don't know which works, which does not work. So this can result in the introduction of new therapeutics for public use that is actually flawed. And finally, this can result in loss of public confidence in science. So, which is more common than thought. There's need to train the mentors. Violation of public trust in science are devastating to all. Do the right thing. When in doubt, don't do it. Coming down to plagiarism, just a few slides. Plagiarism is basically use of someone's ideas or results without citing the source, reproducing something word for word without quotation marks, using a part of a visual without written the source. That's intentional plagiarism. Again, it's a continuum. You have accidental plagiarism, which we don't really know. You are a young researcher, you are a young registrar, you really don't know what is plagiarism, and you really can't think of a better way to say it, so you just take the sentence from a previously published article. So here again, we have a continuum. One end you have deliberate plagiarism, and the other end you have probably accidental plagiarism. Now, if you buy a paper, or steal a paper, you borrow from a paper, it's deliberate. But when you paraphrase, it may or may not be, probably is accidental. If you build on somebody's ideas, like plagiarism of ideas, but you don't cite that person, maybe accidental. Someone told you something and now you're doing it. You really forgot to sort of credit that person. So, why is it so common, plagiarism? Because everyone does it. It's okay if I don't get caught. I was too busy to write that paper. I've got to get that publication. I've got to get a promotion. I did not think this plagiarism. My guy expects too much. These are all the reasons. So what are the common types? You have ideas, you have text, you have self-plagiarism, where you actually quote a paper you have published before word by word. They have authorship disputes. Now, plagiarism of ideas, basically you take an idea, a theory, a conclusion, a hypothesis, and you would make superficial modification without giving credit to its originator. Acknowledging the source of ideas is very important. For example, if you look at streptomycin, the first publication identified Shaz as the primary author along with Waxman, but Waxman got the sole credit. He was the guide and ultimately the Nobel Prize. So an ethical writer will always acknowledge the contributor of others and the source of his or her ideas. Nothing is lost that way. You still get your credit. Then you have plagiarism of text, where you copy a portion of text from another source. You don't give credit to the authors. It's important that if you're quoting something verbatim, you have to enclose that information in quotation marks. Now, one question people ask, when should I cite and when is the citation not needed? If I cite everything, it's going to be a very long reference list. When you need a citation, when you use to refer to someone else's words, when an information is obtained to interview another person, there's a unique phrase you are using, when you reprint diagrams, illustration, chart, pictures, videos, and music. And when you use other people's ideas printed or through conversation or email, that is the time when citation is actually needed. When is citation then not needed? When you write from your own experience, observation, insights, thoughts, conclusion about a subject, when you use common knowledge, the shared information in your field of studies. For instance, a lot of things we know that using a urine culture for UTI, that's common knowledge. Compile generally accepted facts. When you write up on your own experimental results, then again, you don't need a citation. So what is common knowledge? I just told information that your readers will already know. The same information is uncited in other sources. Information that common easily find with general reference sources like an encyclopedia, and general information not quoted directly. Like India is a country of is a large country, not like 1 billion, 3 billion people, but it's a large country. That is something which you know, right? Then you have primary sources, you have secondary sources. Primary source in original work. Secondary sources, analysis of those work, analysis of multiple original works. So these are sources. That inappropriate paraphrasing. I just put this slide because this is the most important form of plagiarism. This may not really be deliberate. What happens is if the original sentence structure is preserved and the paraphrase, such writing is actually plagiarism. And it has been defined as words so close to your source, if the work were placed next to the source, it would be obvious that you could not have written what you did without the source at your elbow. So for example, this is an example. So if you look at this, the original was published in BJUI, Claude Redbone et al. The ALTA study, the second large double-blind placebo-controlled study assessing the impact of alpha-1 blocker alfuzosin 10 milligram once daily on the risk of BPH large progression. It confirms that in men at high risk of serious outcomes from BPH, and the symptom deterioration is by far the main progression event with a cumulative incidence of 14.2% over 2 years. But suppose we rewrite it again, like the ALTA study, Rodborn CG trial is a randomized double-blind placebo-controlled trial, assessed the impact of alfuzosin once daily on the progression. In high-risk men, symptom duration was the main progression event in 2 years, the cumulative incidence of 14.3. Now, the words are different, but even with the citation, this is plagiarism. So it becomes a little complicated as we go along. So there's a slight change. Why is this with a slight change in order? The similar wording, the same order of information, change from the positive to negative construction not enough. So this is the most common form. So there is also self-plagiarism. There's also something called salami slicing. You take an article, you slice it into multiple bits and you report it. And there's also redundant duplicate plagiarism, duplicate publication. And the most consistent pattern when you want to detect is the lack of cross-referencing. So it is considered academic misconduct, it's unethical, it's lying, cheating, and dishonesty. If caught, it can get the writer blacklisted. It's not difficult to detect, actually. We have software, we have Google, we can detect plagiarism very easily in an article that is submitted to us, like Authenticate, for example. So my advice would be to read the instructions well, always acknowledge the contribution, don't use verbatim material. If you do, use them, enclose them in quotation mark, acknowledge your sources, and understand the material completely and use your own words. Don't salami slice. So
2 minutes, please, Arvind.
It's over. Plagiarism, therefore, poses a threat to the integrity of the scientific community. Is one of the most common offenses, often a result of lack of understanding and understanding of the concepts. But an ethical writer always acknowledges the contributions of others and the source of ideas. Thank you so much.
Thank you, Arvind. I know how difficult it is to cover scientific misconduct in something as short as 10 minutes, but thank you for doing a good job. We'll come to the last talk before we take the questions. I've been following the Facebook feed. There are a number of brilliant questions that have been coming up over the last 1 hour, and we'll take them serially from the first question that was asked after I finish the next talk. The next talk is going to be about pseudo journals, and it's again something which is becoming extremely important in terms of a problem that we are seeing across the world. So let me just bring up my screen. I'm hoping you can see my screen now. Just give me 1 second while I work on this screen. Okay, just 1 second. There seems to be some issue with the screen share. Okay. So we're talking about pseudo journals and what are pseudo journals. When you look at it from the perspective of an author believes he's got a manuscript that needs to be published. And there are a bunch of these people who call themselves editors or who call themselves reviewers who are trying to prevent him from publishing. Why do they do this? And what can we do to prevent all this problem from happening? When he finds that it's difficult to publish that one article that he has worked so hard on, he comes up with a solution that a lot of other journals offer him. They say, give me a little bit of money. That's the amount of money I need to process your article, and I will publish it. Unfortunately, these are what we now call pseudo journals or fake journals. So why is this wrong? I have done some research. I believe it's good research. I want to put it out and publish. It costs nobody any money. All you need to do is buy some space on a website. And I would like to publish. Why can I not do this? Why is this wrong? Is that not what most other online journals do? So we come back to the basic concept of why we write, which I talked about in my very first talk. When you read an article that is published in a journal and it says, I took, say, 50 patients of COVID-19, I gave them remdesivir and they improved. Did you actually go and check whether they were those 39 patients? Did you ever go back and check how much they improved? Did you ever go back and check whether they ever got remdesivir at all or not? You never do that. You trust what is being said. You believe what is being said. Therefore, you're trusting the source from which that manuscript came out. And if it came out in the New England Journal of Medicine, you would automatically assume that this has gone through a rigorous peer review. People have looked at it and felt that this is something worth publishing, which is why it is coming out, and therefore you will believe it without verifying. This is the hallmark of a good scientific publication. It's called peer review. On the other hand, when you look at what is called pseudo journals or predatory publishing, the basic problem with such journals is that they publish without a peer review, or at least without a valid peer review. They are therefore preying on the academicians' need to publish, and they were called predatory journals. Over the years, it has now become clear that they are no longer just predatory. They are not simply preying on an author's need to publish. Authors, unfortunately, have become willing partners. They know that this is wrong. They know that this is not as good as trying to get published in a decent journal, and therefore they're willing to become partners and pay to publish. This is therefore now called pseudo journalism or pseudo journals, and no longer are they called predatory journals. An important caveat here is that simply because you're paying to publish doesn't mean that it's fraud. Many good journals expect you to pay, and you will only get published if you have paid them an article processing fee. The difference is that no matter how much you pay, you cannot get accepted unless you meet the basic criteria of science. So you're not paying to get accepted. You're paying purely an article processing fee. So there is a big difference between the two types of journals. So how do you identify a journal as being predatory or a pseudo journal? Some of the common features are that these journals will often publish on unrelated articles, subjects they'll ask you to submit an article on anything. They virtually guarantee a publication. Now they've become smart. All of them will claim that we are peer reviewed. All of them will claim that we will send your article for peer review and we will only accept you if our peer reviewers say yes. But the fact of the matter is that the peer review tends to come back within 3 to 5 days. And if you promise to pay them the money, or if you pay them the money up front, you will never get rejected. So the so-called peer review is actually a sham. So these are some of the emails that I have pulled out from the emails that I have received. I'm sure each one of you has received these emails if you've got your email address on the net. So this is a journal which claimed that they would peer review within 2 days and publish within 5 days. I can guarantee it to you that even if I sit on the heads of my associate editors, they will not give me a peer review back in 2 days. So how can a journal get you back independent, unambiguous peer reviews in 2 days? So even if you think that you will not respond to them once and they will let you go, no, they will not. They will keep getting back to you again and again. So they will keep sending you gentle reminders. So they will badger you for submission. They will expect you to submit anything. So this is a journal of pharmacology and toxicology writing to a urologist asking for an article. Give me anything. And of course, almost all of them will have a US address. You may think you're being smart. You'll go to Google Earth, you'll search for the address, and I guarantee it to you that the address will exist. It will even show a building. Unfortunately, there is no journal inside that building. Some of them have gone on to more obviously fraud practices. Some of them have actually hijacked established websites. They've got websites which look just like genuine websites. They put in names of big academicians on their websites. These are fake academicians. They have misleading claims. They do all kinds of fraud that you can think of just to get that money that you are willing to spend to get your article published. The next big fraud that came about, and unfortunately, we have a major contribution through the Medical Council of India in somewhere around 2010, is validating something called an impact factor. And therefore, this organization called Index Copernicus popped up in Poland and suddenly became a huge money generating agency because they were giving impact factors left, right, and center. This is deceptive because the only impact factor that counts in academia is the one that's given by Clarivate Analytics. And just because you thought you were doing a good job by writing or you have some data, they will actually do the writing for you. And this now extends to even your academic thesis inside academic institutions, where people are willing to write an entire thesis just for some amount of money. All this is fraud, and this goes beyond journals. You now have predatory conferences. So you've become a junior resident or a senior resident in an institution, and you suddenly get an invitation to deliver a plenary talk in an international conference, and you seem mighty pleased with yourself. I've got a global conference, an international conference, and you accept. You put it up on your WhatsApp groups, you put it up on your Facebook groups that I've been invited to an X conference to give a talk. You actually go there, spending some money, paying a small registration fee or paying the conference for the hotel, and the only people in the audience are the 20 speakers. This is now a big problem. This graph tells you exactly how exponentially this is growing, and it's a huge problem. If you're looking at a publication to get recognition, you could do one of two things. Let's assume you're applying for a job for a faculty in a teaching institution, and the person who's taking an interview is somebody who understands pseudo journals. If you put a pseudo journal reference in your CV, he will think one of two things about you. One, that you made a mistake. You don't realize that this is a pseudo journal and you made a mistake in publishing. In that case, I don't want you to be teaching my students, because if you're so naive that you don't know what is good and bad, how can I recruit you for teaching my students? On the other hand, the second thing could be you did actually know that this is a pseudo journal, yet you published in it, in which case you're trying to cheat me. And I still don't want you on my faculty. Therefore, it's detrimental to your academic stature if you've got an article in a journal like this and you put it on your CV. And of course, forget the article forever. The minute you've submitted it to the journal will never give it back to you, and the article is dead. So how can you find out whether a journal is good or bad? The basic idea is, if you've even had to think about it, it's probably bad. But if you have not got yet answers through that, there are a number of websites. There is a conflict of interest here. I'm a secretary of this association. Nonetheless, you could go to the World Association of Medical Editors website, the WAMI, which has a clear guideline on how to identify poor journals. You could look at the directory of open access journals, which again explains what pseudo journals are. There's a website called thinkchecksubmit.org, which helps you ask some questions. And for urology, we actually have a urology green list. This is curated by Henry Wu in Australia. We are members of this, where you actually have a list of good journals for urology. Therefore, if you think it's predatory, it's quite likely it's predatory. And I would seriously advise you to check before you actually get caught. And the IJU has actually been active. We have published 2 editorials on this. The first editorial was simultaneously published by 22 journals. The second editorial was simultaneously published by 7 journals. And both of these editorials have made a significant impact. And the Medical Council of India has now revised its guidelines on what is considered a true journal. And therefore, we believe we've been active in making some of these decisions. So thank you very much for listening to all of us. And I'm now going to try and bring up our regular conversation. So if all the presenters could possibly turn on their screens, and I'm going to try and go through all the questions that we have. So I'm going to take these questions from the time they came. Are you all able to hear me? Are all the presenters able to hear me?
Yes, yes. Rajiv.
Excellent, excellent. So I'll just take the questions one by one as we go along. So the first question I have here came in from Rahul Yadav himself. I think he decided to set the ball rolling by asking the first question. I'll pass on the questions to the respective speakers as we go along. So the first question was, what is the role and benefit of just a meta-analysis without doing a systematic review? So I'll answer this to begin with. You cannot do a meta-analysis without doing a systematic review. A systematic review basically means that you've put in place a system to do a review. You've stated that I will look at all articles published between this time and this time, which should have the following inclusion criteria, should have the following endpoints. You define this, and then you look for articles which fulfill that criteria. That's a systematic review. Once you collect all the data from a systematic review, if you want to reanalyze the data, not just report the data, but reanalyze the data, that becomes a meta-analysis. So you cannot do a meta-analysis without first doing a systematic review. Now, the next question came from Manav, and this is addressed to me. Manav says that if research is reversed as seen of late with PSA coronary and renal stenting, how and why can they get accepted in the first place? What are the lacunae and how could this have been avoided in the first place? An excellent question, Manav, and it's a question which nobody will be able to answer to you to your satisfaction. The problem with science and the problem with what we publish is that it is based on a bunch of 5 to 10 people who at that point of time believe this sounds correct. That's what we call peer review, and that's what we call is current science. It is never based on some solid objective fact which says this only can be true. There's a bunch of peer reviewers, editors who look at what you present, see whether it seems scientifically feasible, scientifically plausible. They look at your methodology, it sounds right, and they go ahead and accept it. What gets published often conceals misconduct. For example, you said I've done 1,000 patients. Nobody will ever check that. No editor, no reviewer will check it. So if there is some misconduct, it could be a reason. And of course, studies can change. Data can change over time. Therefore, this is why science gets published. Some of it turns out to be wrong. Some of it gets retracted over time. We hope that most of such change is simply because scientific facts changed and not because there was misconduct, but we can never rule it out. Therefore, like I said, I will never be able to give you an answer which is 100% satisfactory, but that is the best answer that I can give you, and science does give you a changed answer. Now, the next question that comes up is again from Rahul, which says, systematic reviews are usually by invitation. What does an editor-in-chief look for to invite someone for a review? Again, I'll answer this. Systematic reviews are not necessarily by invitation. At the IJU, we do not require a prior approval for submission of a systematic review. Most journals do not require a prior approval for a systematic review. Systematic reviews are more robust than narrative reviews, and therefore very rarely would an editor look at who the author is while judging the validity of a systematic review. On the other hand, when you're submitting narrative reviews are based on a personal opinion and a personal perception. For a narrative review, the editor will often look at who the authors are. Are they people who you think or you know have sufficient expertise in this domain to be able to give a narrative opinion? And therefore, narrative reviews, at least for the IJU, require a pre-approval. But a systematic review, very often, nobody looks at who the authors are. You simply look at the quality of the review primarily. Now let's go on to the next question. I'm being short in some of my answers because we have a number of them and I would like to cover as many as we can. This is from Gyanendra, and Gyanendra says, statistics is a major hurdle for many. Can you give us some suggestions? Unfortunately, Gyanendra, we cannot give you a lot of suggestions about statistics other than to say that you don't need to know a lot of statistics. You just need to understand some basic facts about which common tests should be applied for which types of studies. The IJU does run a series of these statistical seminars. We will try and put them online if we can. You don't need to be a biostatistician to be able to do the basic statistics. If you are doing a prospective analysis or a prospective study, you will need to understand sample size calculations. For that, you will need help of a statistician if you can't do it yourself. But most other analysis like a t-test, a z-test, a chi-square, and ANOVA can be done through basic tools, basic statistical software, and you don't need to be a biostatistician to do that. All right, the next one. Again, this is from Rahul. This says, usually most of us have research questions in our mind, but sometimes it has a lot of financial burden in like knowing the validity of a new test in a high volume quaternary private setup. How to proceed in such circumstances? Again, unfortunately, I can't give you an answer to how to do a research in a quaternary, or what I'm assuming you're saying, a tertiary or quaternary setup. If you collect data honestly and you ask your research question right at the beginning, that I think this is a problem, let me collect data to answer this question, it doesn't really require a lot of money. I have done most of my research without funding. very little of the research that we do in surgical specialties requires funding. And therefore, a lot of research can be done with negligible funding, but it will depend upon your individual setup to define that. Okay, next one, I think I'm going to let Santosh take it. It's about randomization. So it says randomization without an intention to treat analysis. How should we interpret such outcomes in the light of what has been mentioned in that particular study conclusion? So this is from Rahul. I'm going to simplify this question. What he's basically asking is, how do you assess the validity of an RCT which does not have an intention to treat analysis? Santosh.
Yeah, see, if you're doing a per protocol analysis, like say even the PCLO study looking at prostate cancer screening in America, one of the bigger problem with that study was there was a lot of crossover from one to other. So if you decided that you wanted to do only screening in this guy, active surveillance in this guy, and he no screening, and he went on to the screening arm and then went and took treatment. So there was a lot of mixing of data on each side. So what is the ideal is, why do we do a intention to treat analysis is if there is a minimal movement on each side. But if the major chunk of the data has moved around, then it's a big problem in the intention to treat analysis. So they would have done a per protocol analysis or something like that. So major issue is that you should stick to the protocol. Once you have not stuck to the protocol, all that will come in your consort, and then you will find that the validity of that RCT is gone. That's why I said RCT is not necessarily that because you have done RCT, it's a very good evidence. You have to look at the protocol, how much stuck to the protocol, how many were deviation from the protocol, and the analysis is either per protocol or intention to treat. So intention to treat, when you have divided into two, irrespective of what treatment you have taken it. Per protocol means you have divided, but whatever has been done, you are taking on that. So intention to treat is good, but there shouldn't be much of crossover.
Right, thanks, Santosh. I'll again summarize this in terms of, see, per protocol means everybody got exactly the treatment that was described. Intention to treat means some people dropped out, some people didn't take the treatment. So the intention to treat typically reflects real life far more than a per protocol analysis. But like Santosh said, if there haven't been too many dropouts, then an intention to treat becomes equivalent to a per protocol, and therefore the two can be analyzed equivalently. All right, now let's go on to the next question. This is from Tekanjit. He says, how do we select an indexed journal? So that is a very simple question and a very simple answer. Indexed by common parlance is journals which are indexed on Medline. A surrogate is journals which are listed on PubMed. You must understand the difference between the two. PubMed is like a Google website. It's like a website. It takes its data from two sources. One source is Medline. Medline is a library of the National Library of Medicine of the US. The second source is what is called PubMed Central. PubMed Central is another repository where journals can list themselves. PubMed, when you search on PubMed, it picks up only articles published in journals which are either in Medline or in PubMed Central. The classic definition of indexation was only those journals which were in Medline. But today, we understand indexation to be any journal which is available on PubMed. That is a very gross definition of indexation. All right, the next question. Rahul, how long, just a time range, one has to keep raw data once a study has been published? Again, good question, Rahul. The answer to that is most journals today expect it to be about 5 years. There are a number of associations or societies which have their own guidelines, but a benchmark figure would be about 5 years. The next question came from Nitesh. He says, IJU video journal, is it in the pipeline? So the answer, Nitesh, is straightforward. IJU already accepts videos. There is no separate journal, but you can submit a video to IJU. Anil Mandhani is the associate editor who looks after videos. And if you submit a video to the IJU, if it's a good video, we'll take it. Next question. Do you recommend an online or a distance education course for biostatistics? There are a number of online courses. For example, I did one about 10 years ago, which was run by the Johns Hopkins Institute. There are a number of online courses. I can't recommend a specific one to you, but you can search and take one which is simple. Don't get lost in biostatistics, just keep it simple. All right, now we come to the next question. This is from Rahul Yadav. He says it is better to mention the limitations of a study or a surgical technique, but on rare occasions of a surgical technique, there is no limitation in the hands of the person who wants to publish. And therefore, how do we go about it? So let's understand the limitations part. The limitations when you're describing a surgical technique are not about the surgical technique. The limitations are about the study. The surgical technique may be fine, but the study that was done to assess that surgical technique may have limitations. So you may not have recruited a sufficient number of patients. You may not have followed them long enough. You may have had a large number of dropouts. You may not have got people responding to your phone calls. You may not have had a comparator arm. So the limitations are of the limitations of conduct of the study. Limitations are not about the surgical procedure itself. And there is almost no study which does not have limitations. Therefore, the limitations should be listing the limitations of the study. Next question from Tikanjit is best way to do randomization. The best way to do randomization is to use a random numbers generator. It's available online. Multiple random number generators are available online. They're free. If you're asking me how should the process of randomization be done, it will require a half-day course or maybe even longer. And therefore, the whole concept of randomization would be very difficult to answer in just a Q&A. But if your question is, where do I get a random numbers sequence? It's very easy to get it online. The next question from Prakash is addressed specifically to Santosh again. Santosh, can we register an RCT retrospectively?
No. So what is ideally required is RCT is a prospective study. You have to present it to the institutional review board, the IRB, and the IRB will not give you a registration till you do it with the CTRI.
Okay, we seem to have lost you, Santosh. Santosh, are you still there? Okay, I'll take it forward then. So what Santosh said was correct. Retrospective registration of an RCT doesn't make any sense. Even if you manage to do it for some reason, if you've registered an RCT retrospectively, it loses its validity. And therefore, we do not recommend a retrospective registration of an RCT. Let's move on to the next question. The next question is, does CTRI registration required in a cohort study? Yes, any prospective study can be registered if you're doing an intervention. It doesn't have to be randomized. It doesn't even have to be controlled. Therefore, if it's not randomized and it's not controlled, it becomes a prospective cohort. And yes, you can register this on CTRI. The next question is, in an intention to treat analysis, it is mandatory to have the outcome of all patients, even those who have dropped out, or they are still likely to be included in the denominator when the outcome is not available. So this came from Aditya. It was addressed to Santosh, but I can't get Santosh back on. So I'll answer this. In an intention to treat, Aditya, you have to include everybody in the denominator. There is no reason for exclusion unless the patient was excluded by the oversight committee or the IRB for some specific reason right in the beginning. For all other patients who are in an intention to treat analysis have to be included no matter when they dropped out or why they dropped out. All right, the next question is rather interesting. The next question comes from Manovarul. And Manovarul says, what have we learned from today's session? How important a role is IJU contributing to formulate a treatment principle in the world context? He's addressed this to me. Manovarul, the only thing we are trying to talk about here is how to do a good study, how to read a paper and how to write a paper, and hopefully get more submissions which will be accepted around the world. The IJU does not claim to be doing anything exceptional or great beyond what is its mandate. All right, the next question we have is from Rahul. What would be the best level of evidence that one tries to achieve while formulating a study incorporating a surgical technique, since RCTs are not always possible while comparing a surgical technique with a current gold standard? Again, a very good question. you may not be able to do an RCT with a surgical technique, although many RCTs are currently done with surgical techniques as well. But if you're unable to do an RCT for some reason, the best thing would be to do a prospective trial, a prospective study, which is a cohort study with well-defined primary endpoints and well-defined follow-up, and then compare it with established studies. If you can't do a control arm, if you can't do a trial, the best answer would be to compare it with an to a prospective controlled study, a prospective study which is uncontrolled, and then compare it with established studies. Okay, I am going to try and load it again. We have a major storm coming on outside, so I'm going to try and stay online as long as I can. What would be the, okay, the next question is Apul. Apul, can you hear me? Yes, you're still muted, Apul, so you'll have to unmute yourself. This question is from Dr. Subnis to you. So Dr. Subnis says, why is the abstract only 250 words? Often it is difficult to include everything that you mentioned. It can be extended to 300 to 350 words, and therefore mistakes would be less. So Apul.
So this is actually decided by the editors. Actually, the submission guidelines will state whether it is 300 words. So it is not sacrosanct. I have seen journals where it is up to 300 words. So this is, and if you, as I mentioned in my presentation also, writing a abstract is extremely challenging. But if you, I have seen that we start with 500 words, and if we give time to the manuscript, you can take it down to 250 words, and you'll realize that everything stays. Every data that you think important is still stays. So it depends. It tests your writing ability, but I think 50 words is still doable. And regarding the numbers that you say, 300 or 350, this depends on the editorial board of that particular journal, and these numbers are variable.
Thanks, Apul. I'll give a little bit of a historical perspective of where this 250 came from. This 250 original came from the National Library of Medicine. When they initially started their online registration process, their database could not accommodate more than 250 words in a given field. And therefore they used to restrict it to 250. And subsequently over the years, since we've gone online, the 250 has become, it's become possible to do more than 250, but a standard has been followed. Most journals around the world wish to follow a common standard so that authors don't need to keep changing it every time that there is a new journal that they're submitting to. And that is why most journals still continue to follow a single standard pattern. Okay, now let's go on to the next one. Okay, this is again another very interesting question. There was one about indexing, which we've already answered, so I'm not going to address that again. The next question is again from Rahul, and this is an interesting one. He says, while accepting and rejecting a paper, does the editorial board merit the paper on some objective parameters? Or is it simply based on the subjectivity of a reviewer? Many a times, if some expert paper against a reviewer's belief, he has a denial bias. And I agree with you completely, Rahul. I think we've addressed it a little bit when we were talking about peer review. Unfortunately, there is no scientific parameter which can say good, bad, accept, reject. Ultimately, if you remember some of the historical data, papers which were on classic subjects, which have today become dogmas and standards, were rejected because people at that time believed that this is unbelievable and implausible. Therefore, there are unfortunately no solid objective data. It is not simply a reviewer's comment saying yes, no, yes, no. Editors don't just total up how many yeses and how many no's and then decide. Editors will often go totally against the advice of the reviewers. Supposing two reviewers have said reject, but the editor believes the reason for rejection is not appropriate, he may still accept. On the other hand, two reviewers may have said accept, but the editor feels that the justification is not sufficient or their belief is not enough, may still reject. Unfortunately, this is still an art. Many mistakes are made. It's a given fact that your article which is rejected from one journal will get accepted at another journal, which may even be better than the first journal. All this happens. We all accept it. It's a limitation of our current process, but this is the only one we have, and therefore we continue to accept it. All right, now we'll move on to some more. Okay, Anil has asked a question. Why can't IGU take initiative to make multi-center studies? Because many people have data, but they can't write. So there are 2 or 3 reasons why the IGU can't do it. Number one, the IGU does not have the resources to do it. Number two, it's a huge conflict of interest. If the journal initiates a study, the automatic assumption is that the journal will also publish it. Whereas that simply cannot be true. The journal cannot publish a study just because it was party to its conduct. On the other hand, your question has a very good answer in the sense that there are multi-center platforms that are already available. The Urology Society of India has initiated the National Database of Urological Malignancies, NDUM, where multi-center data is being collected for 5 cancers. We are curating it. I'm heading the database, but many of the members of the IGU are on it. And therefore, if you wish to participate in multi-center studies, the USI has already initiated it. Apart from that, it is up to investigators themselves to collaborate. The journal, unfortunately, can't commission a multi-center study. All right, we're going to move on to the next question. What is the proper way of using someone's study as a reference? Do we have to inform the author of that study? Not at all. You're not required to inform anybody that you're using their study as a reference. You are simply required to read what they have done, write it in your own words, and give a reference to what they have done. That's a proper way. You can't cut paste, but you're certainly required to refer. Next question is again from Manvarul. He says, why do people write guidelines in spite of a very good textbook is there? What should a resident read? Guidelines or textbook? Unfortunately, this is not something we are covering in the journal today or in the seminar today. So I'm going to skip this question for this particular session. Manvarul also asks, why isn't this session wasting my time? I quite understand, Manvarul, that we are not able to answer the questions that you have raised, and therefore we may actually be wasting your time. Where does case report and case series placed in a study, how important are they? This is from Tikanjit. I think case studies and case series are very important. They sometimes answer some very important questions and highlight some very important aspects of disease to us. Therefore, they have a very important role to play as long as you understand the limitations. You can't make associations or assumptions of causality from case report or case series, but they can certainly initiate you into creating a study. Manav has asked a question, why can't one quote the same sentences that one is citing? After all, something is already published and is not a patent. As playing with English is all that most of us do and may end up confusing the original message. Arvind, this is for you. So the question basically is, why can't I cut paste? Why do I have to read it and write it in my own words? This is from Manav. Arvind, you need to unmute yourself.
It's a good question. Manav, the thing is that if we reproduce it verbatim, or even if we do paraphrase it inappropriately, it will be considered plagiarism in the usual sense of the term. I understand your question in the sense, many times, if the author does not have English as his primary language, it's very easy to change the meaning of what is going to be written there. But unfortunately, the way it has to be done now, according to what is commonly accepted, is if you have to quote verbatim, you have to put it in within quotation marks. And generally, if you want to say the same message, you have to write it yourself, paraphrase in a way that it is not plagiarism, and give a reference for it. That's how it is done now. And that's the way it is accepted in the scientific community.
Right, thanks Arvind. So the argument here basically is everybody has a style of writing. And just because you like another author's style of writing, you can't make it your own. You can't claim credit for the style of writing. That is why you can't copy paste. The next question
maybe,
is from
Raji,
yes,
maybe
go ahead.
It can reduce the rate of pickup by softwares if you're just copying that paragraph. Possibly.
But if you're copying it, the software will pick it up.
Yeah, that's the reason I think you need to change it. Otherwise,
well, you see, so the whole question is, why should the software be picking it up? Why should we be bothered? Software picks it up because we configure it to pick it up. The whole thing is more philosophical. Why should we care? So the answer there is, my style of writing may be something I am proud of, and I don't want you to claim that this is your style of writing. Therefore, don't copy paste my stuff. So that's the argument. It's ownership of thoughts, ownership of ideas. All right, next question is from Pankaj Maheshwari. Again, a good question. A lot of peer-reviewed journals are paid, such as urology annals. Should we submit articles to such journals? And the answer, Pankaj, is of course you must. Just because the journal expects you to pay doesn't make it a bad journal. But if a journal is willing to publish you no matter what nonsense you write simply because you pay, then it's a bad journal. But if the journal decides on acceptance rejection based on the scientific merit of your article, it will expect you to pay. Some journals will expect you to pay, and that's perfectly fine. So these journals are absolutely okay. The next question from Manav, and this is addressed to me. Have reputed journals made publication so difficult rather than keeping it simple that they are themselves responsible for the proliferation of predatory journals? A very good question, Manav. Most of us who sit on editorial committees and on associations think about this. Why don't we publish more so that the predatory journals don't have to come up? The answer, unfortunately, is that the quality of the stuff that is getting submitted isn't something that merits publication. The IJU has a rejection rate of about 80 to 85%. Recently, in the lockdown period, which is in the last 2.5 months, we've actually had 3 times the number of submissions that we would normally get in the same period. I actually wrote to all the editorial committee members saying that you have to work harder, that we've got 3 times more submissions in the last 6 weeks than we normally would get. But now that we've processed them, unfortunately, the rejection rate is still the same or even higher, because a journal still believes it has to put out a certain basic standard of science. Now, what you publish in the IJU is clearly not the same high standard that you would publish in the JUROL, which will be not as high a standard as you would publish in the NEJM. So every journal defines what is the minimum standard of science that I would publish. And the only reason that you get rejected is because you don't meet that standard, not because the journal wishes to keep it tight. Therefore, the next we move on to is a question from Lalit. Lalit says, why is there a lack of multicentric studies in India and how can we solve it? So I'm going to give a very simple answer, Lalit. Doing a multicentric study requires a lot of trust. You need to be able to trust your collaborators that they would keep your data honestly, the data you're getting is honest, and you trust that they will give you credit for everything. We unfortunately don't collect our data very well, and we tend to have lots of gaps in our data. We also don't have a lot of faith in each other, and therefore we find it difficult to collaborate. That has been my assumption over the last 20 years, and that needs to change. The next question is from Dr. Ramesh Babu. He says, please elaborate the usual reason an article is rejected by a reputed journal so that people can avoid these questions for an editor. So I'm going to give this to Apul to say what are the common mistakes that cause you to reject. And we'll just keep it very short, Apul, because we've really run over time.
I have covered, actually there are 2 reasons. As I said, one is dependent on the research methodology, the research question, whether it was relevant, and depending on the research question that you had in your mind, whether you chose the correct study design, then you had a proper participant number, whether it was homogeneous, heterogeneous, depending on the research question. So all those things. And then comes your writing skill, whether your the article that you have written mentions everything that you have said in your material and methods. So basically it depends on both these factors, the research methodology, which I say the soul of the article, and how it is presented, which is the manuscript writing component.
Thanks, Apul. So we'll take the next question. This is from Abhik. This is addressed to me. How do you do a comprehensive literature search for a topic? Now, this is a very big question, Abhik. Unfortunately, I can't give you a full answer, but I would suggest you begin by looking for mesh words, medical subject heading. This comes under the NLM category on PubMed. Pick up the most important mesh words that work for your study, put those onto PubMed, and then search down. But this is a very large topic, and unfortunately, other than giving you a very basic answer, I can't go into more details here. Manvurul has now said, thank you for the help. Sure, Manvurul, you're very welcome, even if we did seem to have wasted some of your time to begin with. The next question is from Nitesh. Does acceptance of a paper depend upon the reviewer and the editor's bias for a subject, as some papers rejected by an index journal get accepted in another index journal with minor or no change? So I've actually answered a lot of this already. I will just add a little bit more about how the IJU works, and every journal defines its scope of work. As an Indian journal, we tend to have a lower threshold for accepting articles which are very specifically addressed to conditions which are India or regional specific. Therefore, if you give me a good article on conditions which are India specific, or conditions or treatment outcomes which are very regional specific, we are more likely to accept that than if you try to mix with something which is already published in 10 other journals. Therefore, like I said earlier, yes, it is subjective. Yes, unfortunately, what may be accepted by one may be rejected by one will be accepted. All that is true. It is unfortunately a very subjective piece of decision making. We try to keep ourselves as unbiased as we can, but we, yes, do get influenced by the topic. And if the topic is something which we think will interest our readers, our threshold for acceptance may actually come down. So that actually should answer the next question that Venkat also asked. Venkat Gite asked that what criteria are followed while accepting or rejecting. I think that answers that question. I know all of you would like a clear checklist. Yes, 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 score 7 out of 10 and your article is accepted. Unfortunately, none of us can give you such a checklist. It is unfortunately still rather subjective. We accept our limitations and our bias, but that's unfortunately all we can do for the moment. There's one more question that's come in from Chandramohan. Brief comment on ethical committee. Chandramohan, a very good question. Ethics committee approvals have become mandatory for every prospective study. Over the last 2 weeks, if you have submitted an article to the IJU, you will start getting more of them sent back to you with a clear set of questions that you have to write the following 4 statements in the methodology about ethics. It's become extremely important. We are no longer accepting articles without a clear ethics statement. Unfortunately, ethics committees are still difficult to come by. Therefore, we would still recommend you follow the ICMR guidelines on ethics as far as possible. We understand it is difficult. We try to work around it, but that's unfortunately the requirement. The next question is, why does IJU not give preference to Indian authors? Pankaj says this. Pankaj, that is absolutely untrue. If you look at the publications in the IJU, about 70% of the publications in the IJU are from Indian authors. Only about 30% are from foreign authors. If you look at the submission ratio, we present this data every year at the UCCon. Every year we present this data. About 1 in 3 of all submissions are from foreign authors, and 1 in 3 of all acceptances are from foreign authors. Therefore, the acceptance rate from foreign authors is no higher than the acceptance rate from Indian authors. It's actually exactly the same. And it's been consistent for the last 7 years. I can show you data for the last 6 or odd years that we've been presenting it. It is exactly the same acceptance rate. On the other hand, I will be honest to say I actually have a little bit of a bias towards Indian submissions because we believe that Indian people work in more difficult circumstances. Therefore, even if the number of cases is smaller, but we feel that the question being answered is very specific to India and Indian circumstances, our threshold actually comes down to accepting that article. So I will not accept that we are biased against Indian authors. If anything, we're actually biased for Indian authors. Okay, now we're getting a flurry of questions and I'm not sure we'll be able to address all of them, and the moderators will have to tell us when to shut up, and we will actually stop whenever they tell us to stop.
May I pitch in?
Sure, of course, Anil.
Yeah, Rajiv, I think we must commend Manu's remark, and we need to really improve, not to waste their time.
Okay, so that was Manu Arul. We are wasting their time, and therefore you would want us to stop. But the beauty of an online platform is anybody who doesn't like us can log off. So that's quite an okay. I'm going to take the next.
We need to improve ourselves.
Oh, we need to improve ourselves. There's no doubt about that. We're never short of that. We'll take the last 2 or 3 questions, then we'll stop. So the next question is. Okay, so I've got a comment from the moderator. It's okay to continue. So we will continue till we are actually closed. All right, hang on a second. I have to go back to where I lost track of my questions.
Rajiv, in the meantime, can I interrupt for the thing? Because
Sure,
it's a major thing for private practitioners.
Right.
A lot of private practitioners think where I'll get a IRB and how will I get a IRB clearance. So I clarify, if you go back to my slide, you'll see what a IRB constitutes. But you, as a private practitioner, you can't make your own IRB. The simple route I would suggest Dr. Vaddi is to, Dr. Chandravan is to go to the closest medical college. They'll have IRB there, and you can put your study there, and for a small fees, they will accept it and take it forward. But it is not good to do a prospective human study intervention without IRB approval and CTRI.
Okay, I'll go back to the question feed. Dr. Pal had raised a question, should every article have a different message? In an ideal world, Dr. Pal, yes, every article should have a different message, but that doesn't always happen. Therefore, there is a very strong place for studies which reiterate an existing data. So even if your study is simply re-supporting or restating existing data, it may still be valuable. Let's take a very strong example from COVID right now. You've already got data on remdesivir, but even if 10 more studies come out on remdesivir, all of them are likely to be accepted, even though they may come back with the same data and nothing new. Therefore, until some piece of information becomes accepted as absolutely standard, more articles on the same subject will continue to be get published. But when 20,000 patients have been published about a particular procedure, sending another 200 will probably not get published. Therefore, there is a threshold as to when people decide that I don't want any more reiteration of the same fact. All right, the question is, what is ICMR guideline? This is from Kaushik. Kaushik, it's on the ICMR website. It defines how an ethics committee should be structured, who should be members of an ethics committee, and I will not say more about that right now. Manas has asked a question, it's addressed to me. What comprises an ethics committee if an author working in a private wants to conduct? So Santosh has answered this very well. I am not going to go back and address this because we don't have any further answers to that. Ethics committee approval mandatory for retrospective studies. This is from Sunirmal. Sunirmal, the answer is yes. Any study reporting human subjects or even animal subjects for that matter requires an ethics committee approval or waiver. So even if you're simply pulling out case sheets and you're reporting data from the past case sheets, you are required to write your ethics committee for an approval. The ethics committee may say, you don't need an approval, we provide you a waiver. But that decision of whether to take it to the full ethics committee or simply provide a waiver rests with the ethics committee. So the simple answer in one word is yes. If you're reporting a human or an animal study, you are required to get an ethics committee approval. So question that Sunil says is that our ethics committee requires insurance for patients enrolled in any interventional study, prospective cohort or RCT, even if it's not novel. I understand the problem that you're raising, Sunil. Unfortunately, these are requirements that the ICMR guidelines will specify what needs to be done. Just because it is difficult to fulfill a law doesn't mean that the law is wrong. We still have to try our best to address all the questions that have been raised by the ethics committee. All right. Is there a way to detect statistical misconduct? Yes, there is a way of detecting statistical misconduct. At the IJU, we do this, but there is very little way of judging whether you actually had 100 subjects or you only actually had 80. For that, to do that, the journal has to have an index of suspicion. If we have suspicion, we will ask you for your raw data. Again, the IJU has done this on at least 2 or 3 occasions in the last 3 or 4 years, where we've had problems with data. We've asked the authors to give us phone numbers or data of their patients, without which we will not publish, and therefore we have not published because the authors could not give us raw data. So the journal can ask you for raw data. We can pick up statistical misconduct, but it is a little difficult. We trust our authors to a large extent. All right, how can I make a pro forma which can be used for future retrospective studies? Now that's interesting. Why would you want to do a retrospective study in the future? Why can you not do it as a prospective study for today? The only reason you would do that is that you want to generate an institutional database which you can question later on. That would then become a retrospective study in the future. So doing a retrospective study in the future is common because institutions develop institutional databases which they then question many years later. It's not the best way. The best way is to ask your question upfront and design your database to answer that question. Because assuming you've collected 10 pieces of data, but 5 years down the line, you realize that the question that you're asking cannot be addressed from the data that you collected, then the database becomes useless. Therefore, you should try and do prospective data collection rather than a retrospective. Okay, we've got a flurry of questions and we are going to have a bit of an issue about how many we can address. Does the IJU start multi-center studies? I think we've addressed this. The IJU cannot commission multi-center studies. USI can. The USI platform called the NDUM currently looks only at malignancies, but it can easily be expanded to look at stone disease, something which the Crows did for the SIU. And if we have sufficient number of people who are interested, we can certainly expand the NDUM database to include stone disease. Sunirmal says CTRI does not accept retrospective studies, but journals want a registration number. Absolutely correct, Sunirmal. I think this was answered earlier by Santosh about CTRI. You cannot register retrospectively. So if you have failed to do it at the time of starting, you have no choice but to go without a registration. All right, I have a feeling we may have answered almost everything that we have right now. This is the last question I saw. If somebody has another question, they want to put it up on Facebook right now. I'm live on the Facebook at the moment to see question. I see the last comment as Kaushik's, which is about PCNL app, but nothing else. So if there is nothing else, anything else, I'd like the speakers to have a last comment each if there's anybody who wants to say something among all our speakers. Okay, so if there's nothing else to be said, we would like to thank you all for having been here. We've been here for nearly, over 2 hours. We've actually been here for 2 hours and 20 minutes, which is very reassuring to those of us who think we're doing a very esoteric job of writing. But we seem to have had a very good attendance. We'll get data from the Alto group a little later. Thank you all for contributing your Sunday mornings. 2.5 hours is a lot of time. Thank you for being here. We'll sign off with this. Thank you.
Thank you.
Thank you.
Yes.